Right now, inside the chests of, well, millions of people, there's this bizarre biological mutation happening.
Yeah, it really is wild.
Right. I mean, human tissue is literally rewriting its own genetic script.
Hmm.
It is transforming the lining of the throat into something that resembles the stomach just to survive.
And it sounds totally like science fiction.
It completely does.
Yeah.
But it usually starts with something that we brush off entirely, like you have a great meal, you lean back on the couch, and then you get that sudden searing heat rising up in your chest.
Exactly. And we treat it so casually. I mean, we just pop an antacid, maybe blame the spicy takeout, and move on.
Yeah, but that momentary burning is actually a window into a remarkably complex failure, right? Like mechanics and anatomy and cellular biology.
It really is a perfect example of how an everyday annoyance is secretly this evolutionary battleground happening inside the body.
Today's deep dive is an exploration into the surprisingly complex world of gastroesophageal reflux, or GERD. Our mission here is to unpack the volcanic plumbing of the human body, discover how a simple valve issue triggers that crazy cellular mutation, and uncover the historical accidents that built our modern medical understanding of it.
And the completely wrong guesses, too. There were a lot of those.
Ah, so many. Okay, let's unpack this because we need to establish a really important baseline right out of the gate for everyone listening. Reflux, just the physical act of stomach content splashing up into the esophagus, happens to everyone.
Yes, it happens to you, to me, multiple times a day.
Right.
But that is just GER, right? Gastroesophageal reflux without the D at the end. It is a completely normal physiological event. Your stomach contents move retrograde, so back up into the esophagus.
And for most people, that's just after meals and you don't even consciously notice it.
Exactly.
But wait, what exactly is in those, because we always just call it acid, but it's more of a chemical cocktail, isn't it?
Oh, it is a very harsh mixture. I mean, you have hydrochloric acid, of course, but you also have pepsin.
And pepsin is an enzyme, right?
Right. It's an enzyme designed by the body to break down the proteins in, say, the meat you eat. But the problem is your esophagus is also made of protein.
Oh, man. That's not good.
No, it's not. And you also have bile and pancreatic enzymes that can actually wash up from further down in the intestines.
Wait, bile? Isn't that just for fats?
Basically, yeah. Bile is essentially a biological slurry meant to dissolve fats. So you have acid, protein-digesting enzymes, and fat-dissolving bile all just sloshing around together.
Yikes. So when does that normal sloshing actually get the D? Like, when does it officially become a disease?
Well, it only earns the label of GED, so gastroesophageal reflux disease, when that normal event starts causing troublesome symptoms or visible tissue damage.
Which, I mean, that sounds incredibly straightforward. But from what we're looking at in the sources, that line between normal biological function and disease created this massive historical headache for doctors.
It was absolute chaos for decades. Because, troublesome is entirely subjective. What doctors kept finding was that the physical damage they could see with their own eyes didn't always line up with the pain the patient was actually reporting.
I love the analogy in the research here. It's like having 3 different mechanics trying to diagnose a problem with your car, but they completely refuse to talk to each other.
Yes, that perfectly describes it.
Right. So first, you've got the gastroenterologist.
Right.
They are the mechanic who only looks under the hood at the engine. They use an endoscope, like a camera down the throat, and they are purely looking for physical wear and tear. Redness, visible erosions, bleeding ulcers.
Right. They want tangible visual proof of damage.
Then you have the physiologist. They are the mechanic plugging a diagnostic tool into the car's computer sensors. In this case, they are using pH probe data.
Which is pretty wild to experience, by the way.
Yeah, I read about this. They literally snake a thin wire down the patient's nose, leaving a sensor dangling just above the stomach for a full 24 hours. And it just measures the exact concentration of hydrogen ions.
Exactly. They only care about objective chemical exposure, specifically how many minutes the esophagus spends swimming in fluid with a pH below 4.
So to them, the disease is purely a math equation of acid exposure over time.
Exactly. And finally, you have the primary care doctor who is just sitting in the passenger seat listening to the driver complain about a weird noise.
Right. They're diagnosing based purely on symptom frequency. A patient says, hey, I have heartburn twice a week. And the doctor says, okay, you have GERD.
So you can imagine the confusion when those 3 lenses completely disagreed on the exact same patient.
Right, like the GI doctor says the esophagus looks pink and perfectly healthy.
But then the physiologist looks at the probe data and says the acid levels are completely off the charts.
And the primary care doctor says the patient is in absolute agony. So, like, who do you even treat?
It was a mess, and it actually took until 2006 to get everyone on the same page.
Really? Is that recently?
Yeah. A gastroenterologist named Nimish Vakil convened an international panel of experts to hammer this out. They published what is now known as the Montreal Definition and Classification of GERD.
And they made a pretty radical shift, didn't they?
They did. They centered the definition entirely around the patient. They defined GERD as a condition that develops when the reflux causes troublesome symptoms and or complications.
So they made the subjective human experience the anchor for the whole thing.
Yes, it was a really vital admission by the medical community that, you can have severe reflux disease with a pristine, healthy-looking esophagus. And conversely, you can have someone whose esophagus is severely eroded by acid, but their nerves are just dulled and they barely feel a thing.
That is so strange. And that Montreal panel also formalized a really crucial three-way split in how we classify the disease today, right?
Yeah.
Because they realized they weren't dealing with just one monolithic condition.
Exactly. They broke it down into 3 clinical buckets. First, you have erosive GERD. This is the classic presentation where there is visible acid damage and erosions.
Okay, that makes sense.
Second, you have NERD, which stands for non-erosive reflux disease. This is where the pH probe shows abnormal acid levels backing up, but the tissue miraculously looks totally fine.
And then the third bucket is the one that really seems to trip people up. Functional heartburn.
Functional heartburn is fascinating. The acid exposure measured by the probe is totally normal. The tissue looks completely normal.
But the patient is still in pain.
Very real, very severe pain. It's thought to be an issue of esophageal hypersensitivity. The nerves themselves are firing off pain signals at the slightest drop of normal acid.
Wow.
This raises an important question, though. If someone's pain is caused by hypersensitivity, but their actual acid volume is normal, what happens when you give them traditional acid-blocking medication?
I would assume it just doesn't work at all.
It doesn't. And that is a huge source of clinical failure today. Patients with functional heartburn often don't respond to standard proton pump inhibitors or PPIs because excessive acid just isn't their primary problem.
Because if you treat them like a classic GERD patient, you're treating a nerve problem with a chemistry solution.
Exactly. It fails.
So if the problem isn't always the tissue, but rather the nerves or the acid volume, it makes me wonder, how is the fluid getting up there in the first place? I've always just been told I have a weak valve, but looking at the anatomy, it seems way more complicated than just a single flap.
It is. The barrier meant to keep your stomach contents in place is actually a highly coordinated double pinch system. It's 2 overlapping structures working together at the gastroesophageal junction.
Okay, so the first pinch is the lower esophageal sphincter, or the LES, right?
Right. Think of the LES as a thickened ring of smooth muscle at the very bottom of the esophagus. It maintains a baseline tone, so it stays contracted most of the time just to keep the door shut.
And then the second pinch comes from the outside.
That's the crural diaphragm. It's a muscular part of your diaphragm, which is the sheet of muscle you use to breathe, and it wraps right around the esophagus as it passes through into the abdomen.
So it acts as an external pinch valve.
Exactly. And this is crucial because it reinforces the LES during moments of high pressure. When you cough or bend over or lift something heavy, your abdominal pressure spikes.
Right.
The crural diaphragm reflexively squeezes tight to make sure the stomach contents don't just shoot upward under that pressure.
But this beautifully synchronized double pinch system can break down structurally, right? Like the most famous example is a hiatal hernia.
A sliding hiatal hernia, yeah. This happens when the top part of the stomach literally slides up through the opening in the diaphragm and into the chest cavity.
So it pulls the LES up with it, and suddenly those 2 pinch valves are separated. They aren't overlapping to create that seal anymore.
You lose the double pinch effect completely. The structural reinforcement is gone. Interestingly, though, many people have hiatal hernias and never experience reflux symptoms. Yeah, but if you do have erosive GERD, a hiatal hernia is very often the structural culprit, making it much, much worse.
But here is the wild part to me. For a long time, doctors thought everyone with GERD just had a permanently floppy, weak valve that stayed open all the time.
That was the assumption, yes.
But then, in the 1980s, an Australian physiologist named John Dent completely upended that idea.
He really did. Dent used a tool called esophageal manometry. It involves swallowing a catheter covered in pressure sensors to map out the exact muscle contractions of the esophagus in real time.
Which sounds incredibly uncomfortable.
Oh, I'm sure it is. But what his group discovered was that most reflux episodes, even in severe GERD patients, weren't happening because the valve was permanently broken.
Right, they were happening because of something called TLESRs, transient lower esophageal sphincter relaxations.
Exactly. What happens is you eat a meal, and your stomach stretches to accommodate the food. Stretch receptors in the stomach wall send a signal to the brainstem, and the LES reflexively pops open for a few seconds.
And this has nothing to do with swallowing.
Completely independent of swallowing. It's an evolutionary release valve. It's supposed to happen so you can vent trapped gas. I mean, it's the biological mechanism behind a burp.
Okay, I am trying to visualize this. It's not that the door to a nightclub is broken off its hinges, leaving the entrance wide open all night.
Right.
It's more like the bouncer at the door is actively choosing to unhook the velvet rope and let the wrong people out at the absolute worst possible times.
That is an excellent way to think about it. The bouncer isn't broken, you know. The bouncer's just confused.
Wow.
Everyone has TLESRs. The difference is that in GERD patients, that bouncer opens the door and lets out highly acidic liquid instead of just venting gas.
Right.
Dent's discovery was a massive paradigm shift. GERD went from being a purely structural problem to a timing problem.
But wait, I'm struggling with the physics of this a little bit. If I just ate a massive dinner, let's say a huge plate of pasta, the stomach is churning it all up like a blender. Shouldn't all that food act like a giant sponge and neutralize the stomach acid? Why is the fluid that escapes right after a meal so damaging?
That exact question puzzled clinicians for a very long time. The answer actually wasn't discovered until 2001 by a researcher named Jonathan Fletcher. He used highly specialized sensors and found something called the acid pocket.
The acid pocket? That sounds ominous.
Well, Fletcher found that the stomach isn't actually a perfect blender. After you eat, the food does buffer the acid in the main body of the stomach, but a distinct layer of newly secreted, unbuffered, highly concentrated acid forms and literally floats right on top of the food meal.
Because the top of the stomach doesn't churn as aggressively, right? So it doesn't mix.
Exactly, so it just floats there, like an oil slick on top of water.
And where does that highly acidic oil slick sit? Right at the very top of the stomach, resting directly against that LES valve.
Exactly. So when that confused bouncer inappropriately opens the door during a TLESR, the fluid sitting right there waiting to escape is the most acidic fluid in the entire stomach.
So the bouncer opens the door, the acid pocket spills out, and now this highly corrosive fluid is bathing the esophagus. What actually happens to the tissue when they make contact?
This is where we see a really profound difference in cellular engineering. Your stomach is built like a fortress to handle acid. It has a thick mucus bicarbonate layer. Bicarbonate is highly alkaline, like baking soda, so it neutralizes acid on contact.
And the stomach also rapidly replaces its surface cells, doesn't it?
It does, but the esophagus doesn't have any of that. The esophagus is lined with squamous epithelium. Imagine flat, scale-like cells stacked tightly together like paving stones.
Okay, paving stones.
It's great for letting a rough piece of food slide down, but it has no mucus armor and no bicarbonate buffer. It relies almost entirely on just getting the acid out of there as fast as possible.
So it relies on clearance.
Yes. First, mechanical clearance through peristalsis. That's the muscular waves that actively push the fluid back down into the stomach. And second, chemical clearance through swallowed saliva.
Oh, really? Saliva.
Yeah, your saliva actually contains its own bicarbonate to wash away and neutralize the residual acid film left on the walls.
Which perfectly explains why reflux can be so devastating at night. Because when you are asleep, you aren't swallowing much, and your saliva production absolutely plummets.
Exactly.
Acid escapes, the esophagus doesn't clear it, and it just sits there, burning the paving stones.
And that chronic injury sets off a vicious cycle of damage and healing. Clinicians grade this physical damage using the Los Angeles classification, which ranges from grade A, so tiny little mucosal breaks, all the way to grade D, which involves deep circumferential ulcers wrapping entirely around the esophagus.
Here's where it gets really interesting, though. Because if that cycle of burning and healing goes on long enough, the tissue realizes the paving stones aren't working, and it actually mutates.
It does.
And this brings us to one of the greatest historical ironies in medicine, Norman Barrett.
Ah, yes. Norman Barrett was a brilliant British thoracic surgeon in the 1950s. He started noticing patients who had severe chronic ulcers in a section of their lower esophagus.
Right. But when he looked closely at the tissue under a microscope, it didn't look like flat squamous cells. It looked exactly like stomach lining, tall columnar cells that secrete mucus.
So Barrett publishes this major finding, and he basically says, aha, This section isn't the esophagus at all. It's a pouch of the stomach that got trapped above the diaphragm when the person was born.
And he was completely 100% wrong.
So wrong. A few years later, other researchers, Allison and Johnstone, they proved that it actually was the esophagus.
Right.
The tissue hadn't been pulled up from the stomach. The esophagus had literally rebuilt its own cellular structure.
The stem cells in the esophagus, in a desperate attempt to survive the constant acid bath, stopped producing vulnerable squamous cells. Instead, they transformed and started growing acid-resistant intestinal-type columnar cells.
It's just an incredible survival mechanism. But the irony is, even though Norman Barrett got the mechanism entirely backwards, the condition is still named after him to this day. Barrett's esophagus. It is a lasting monument to a misdiagnosis. And, while that cellular transformation is a clever short-term survival trick by the body, it carries a very dark long-term consequence.
Yeah.
Those mutated cells are unstable. Barrett's esophagus is the single strongest known risk factor for esophageal adenocarcinoma, which is a highly aggressive type of cancer.
Which is terrifying because the rates of that specific cancer have been rising incredibly fast in Western countries over the last few decades.
It really has.
And understanding how that tissue mutates brings us to a massive ongoing debate in the medical community about why this is happening.
This is one of the most fascinating epidemiological puzzles today, and it revolves around a bacterium called Helicobacter pylori, or H. pylori.
The famous bacteria that causes stomach ulcers and stomach cancer.
That's the one. For a long time, H. pylori was public health enemy #1. But in the 1990s and 2000s, researchers like Martin Blaser started noticing a paradox.
Okay, what kind of paradox?
Well, as we successfully eradicated H. pylori in the industrialized world using antibiotics and better sanitation, the rates of GERD, Barrett's, and esophageal cancer started skyrocketing.
Wait. Are you telling me that a bacteria that literally causes stomach cancer might actually be protecting us from esophageal cancer? That is a wild evolutionary trade-off.
If we connect this to the bigger picture, the biochemistry makes a strange kind of sense. H. pylori survives in the stomach by secreting an enzyme that produces ammonia, which neutralizes acid locally.
Oh, wow.
Furthermore, a chronic H. pylori infection damages the parietal cells. Those are the microscopic factories in the stomach lining that actually produce hydrochloric acid.
So less acid produced overall means less acid available in the acid pocket to reflux into the esophagus.
Exactly. Blaser's hypothesis is that by wiping out this ancient bacteria, we restored our stomachs to their full, highly acidic potential. We fixed the acid factories.
But we did this just in time for modern, highly processed diets and rising obesity rates to put immense mechanical pressure on our esophageal valves.
Exactly. It shows how curing one disease might inadvertently fuel another by changing our baseline internal environment.
So if we are dealing with stronger acid and failing bouncers, how do we fix it? We mentioned the PPI medications earlier, but the history of fixing the mechanics is also full of accidents. Take Rudolf Nissen in 1955.
Another happy accident. Nissen was a surgeon operating on a patient with a severe peptic ulcer. To reinforce the damaged area, he wrapped the top part of the patient's stomach, the fundus, all the way around the lower esophagus and stitched it in place.
He was basically just trying to patch a hole in a tire.
Pretty much. He didn't set out to cure reflux at all, but he noticed afterward that the patient's severe reflux was completely gone.
Wow.
By wrapping the stomach around the esophagus, he had artificially recreated that external pinch valve we talked about earlier. The Nissen fundoplication was born, and it remains the gold standard surgical fix today.
But most people don't get surgery right. Most people take PPIs, proton pump inhibitors, which hit the market in the 1980s and changed everything. How do they actually work?
Well, the proton pumps are the mechanisms inside those parietal cells that physically pump hydrogen ions into the stomach to create acid. PPI medications systematically shut those pumps down.
So they just turn off the tap.
Basically. They are incredibly effective at reducing acid volume, making them miracle drugs for healing visible erosions.
But there is a huge caveat to PPIs that we need to talk about regarding the physical defect.
This is a critical but. PPIs do absolutely nothing to fix the broken mechanics. They don't tighten the LES, and they don't stop the stomach from triggering TLESRs.
Right. The bouncer is still opening the door.
The fluid is still backing up. It's just less acidic. Which means if your reflux contains bile or pepsin, which PPIs don't stop, you can still be sustaining microscopic esophageal damage even while taking maximum dose medication.
Which is why there is a renewed interest in mechanical fixes today. You don't have to get a full stomach wrap anymore. There are newer devices like the LANX.
Right, the LANX device.
It's literally a little bracelet of titanium magnetic beads they surgically place around the esophagus. The magnets hold the valve closed against stomach pressure, but they pop open when the downward force of swallowing pushes food through. It treats the mechanical failure mechanically.
It's an elegant physical solution to an actual physical defect.
So what does this all mean? We've covered everything from mutating paving stones to historical misdiagnoses and magnetic bracelets. How does this connect to the everyday advice doctors give you for reflux?
It perfectly explains the advice if you look at the mechanics. Why do doctors tell you not to eat a massive meal late at night? Because gastric distension, so a stretched stomach, is the #1 trigger for those inappropriate valve relaxations, the TLESRs.
Why are you told to elevate the head of your bed?
Because of the acid pocket and clearance. If you lie perfectly flat, that unbuffered layer of pure acid is resting right against the valve.
Just burning a hole in things.
Right. And without gravity to help your esophagus clear it through peristalsis, any leak will sit there burning you for hours. Elevating the bed enlists gravity to help push the acid back down.
It is incredible to think about the invisible tug-of-war happening in your chest every time you feel that slight burn. But here is something else to mull over. We talk about how wiping out H. pylori changed our internal environment. Today, millions of people are taking new GLP-1 weight loss drugs, which work in part by significantly slowing down gastric emptying.
Meaning the stomach stays fuller for a lot longer?
Exactly. If the stomach stays stretched and full for hours on end, that means constant pressure on the LES and a constant trigger for those TLESRs to pop the valve open. As we manipulate our biology to solve the modern obesity epidemic, we might inadvertently be ushering in a completely new era of mechanical reflux challenges, putting even more pressure on a valve that is already struggling to keep the door shut. Keep that in mind the next time you reach for an antacid.